So for the first talk, I would like to invite Dr. Alisha. I request Dr. Chintan ma'am, Dr. Arya sir to kindly come on stage to chair the session.
Okay, good morning everyone once again. So we will be talking about the corneal topography and tomography. So what is a corneal topography? It is the graphical representation of the geometrical properties of the cornea, whereas a tomography is an elevation based representation of the cornea. So why do we need a corneal topography, right? So what is it used for? For the corneal curvature, the keratometry. So if you already have a keratometry which can give you the values, so why do you then need a topography for? Right now, that is the reason is because it is the keratometry is not sufficient in cases of refractive surgery and for diagnosing the corneal ectasias in the early stages specifically, where the accurate analysis of the whole of the anterior surface as well as the posterior surface of the cornea is required. So there were various principle-based systems that have been there for the corneal topography and tomography. The placido-based principal devices include your placido disc and the video keratoscope. Then there was the slit scanning system, which was used in the OBSCAN. And then came finally the Scheimpflug imaging, which is being currently used, which includes your Pentacam, the Sirius and the Galilei devices. So the placido based devices basically works on the principle that the cornea acts like a convex mirror and the reflected image is viewed either directly using a placido disc or it is captured and then analyzed as is done in a case of a video keratoscope. So what happens in that is the Myers that you are seeing, depending upon the distance in between the Myers, you can tell whether there is flattening or steepening. As in this example, you can see that the Myers are closely placed. So that means there is steepening in that area of the cornea. A corneal video keratoscope is also based on the placido disc based principle, but that is going to actually capture the image and it will give you the overview in this format. So you can see that the video keratoscope is showing you the axial curvature map and the keratometry maps. This can also provide you the elevation map, but you have to remember that it is only capturing the anterior corneal surface. So whatever the elevation readings that are being given to you is on the basis of it is being calculated and it is not the real elevation based value that is calculated. Now the OBSCAN is based on the scanning slit system. This is not used nowadays, but you should just have an idea about what it is. So in this it is actually used to derive the actual spatial location of the 1000 of the points on the corneal surface, and a series of slit lamp beams are compiled across the cornea to create a profile of the cornea. So this uses actually the concept of the elevation and the reference surface. A reference surface, typically a sphere, is constructed by fitting the reference surface as smooth as possible to the data surface, which is known as the best fit sphere. And depending upon what the patient's corneal surface, whether it will be above that best fit sphere or below that best fit sphere, it will be represented in the form of certain color scales, right? So the hotter colors, that is towards the red, they means that the surface is elevated, and the cooler colors, which is towards the blue, it will mean that the patient surface is below the reference surface. So this is how a OBSCAN quad map used to look like. It basically gives you the elevation map, which is the anterior and the posterior elevation map of the corneal surface. The curvature map is provided and the pachymetry map or for the corneal thickness is provided. But what were the limitations of the OBSCAN? The pachymetry lags in accuracy and the reproducibility to the Scheimpflug devices and the readings were not interchangeable, and it inaccurately identifies the post-operative posterior corneal surface and routinely locates the surface too anteriorly. So that is why now we have shifted to the Scheimpflug imaging. It is based on the Scheimpflug law, which states that to get a higher depth of focus, we move the three planes, which is the picture plane, the objective plane and the film plane, so that it cuts at one point of intersection. Now this is how a map refractive of the pentacam looks like. So you can see on the left side of the map is provided the patient details on the topmost corner. Then in below that is provided all the quantitative values of the cornea. This we are going to discuss in detail. And then on the right side you have the 4 maps, which includes your axial or the sagittal curvature map, the elevation map, which is for the front and the back surface, and then you have the corneal thickness or your pachymetry map. So what does the elevation map depicts you? So this is again on the basis of that best fit sphere that we have already talked about. This will the above image is the front elevation map and the below image is the back elevation map. So first you have to compare, you have to see the color scale that is provided along with this map, right? So this we have discussed earlier also. I'm repeating it once again, that the hotter colors, which is towards the red, depicts the elevation, and the cooler colors, which is towards the blue, will depict the that it is below the normal the reference surface, right? So normally the elevation on the front surface or the anterior surface should be less than 12 micron. The back surface normal value is less than 17 micron, and the difference between the front and the back surfaces should be less than 5 microns. Now this is a sagittal curvature map. So what you can see in this is again that the color scale is provided to the left of the map. You can see that a pattern is being formed on this curvature map. So this, since we are talking about the normal pentacam map over here, so this is a normal symmetrical bow type pattern that you are seeing, and this is showing a regular astigmatism, right? Then comes the pachymetry map, which provides the corneal thickness. And this is actually, the pentacam is actually providing the true thickness of the cornea, because it is measuring your anterior as well as your posterior corneal surface. So again, this is a normal pachymetry map. That is why the center of the cornea, you can see that it is green in color, which is depicting the normal cornea, whereas since the cornea is prolate in shape, so that is why you can see that the periphery of the cornea is little thicker, and that is why it is showing in blue color. Now what were the various values that we have seen in the first map that was seen on the left side of your pentacam map? So the keratometry values for the front and the back surface of the cornea is there. So K1 and K2, as we have discussed in the keratometry lecture also, is being depicted over here also. Km is the mean keratometry value, then is the astigmatism, then is the radius of curvature, the minimum radius of curvature, and the radius for the horizontal vertical curvature and the mean curvature is also provided. The axis of the astigmatism is provided, and the radius of curvature in the peripheral 9 mm cornea is provided, right? There is another thing that you have to look upon whenever you are capturing the pentacam map, which is the Q value, the QS value. That is actually the quality specification, which should be okay. That will mean that the map that you have captured is of good quality, right? For example, in this case, you can see that it is coming blinking. That means you need to repeat this map. Now, below that, there are certain other parameters that are provided, which tell you the pachymetry, which is at the center, the pupil center of the cornea, the pachymetry which is at the apex, the pachymetry, the thinnest pachymetry. Now these pachymetry values, their coordinates are also provided to you, so that you can actually visualize it on the map where the pachymetry value is actually located, or where the thinnest point of the cornea is actually located, which helps you in diagnosing various pathologies of the cornea. Then the Kmax value is also provided, which is the maximum keratometric value. Now there are certain additional parameters also which are provided on a pentacam, which is the cornea volume, the anterior chamber volume, and the AC depth. These all factors, they help you in a case of glaucoma as well, and also it helps you in telling the amount of the intraocular pressure that has to be modified depending upon the corneal thickness. The angle is also measured in this, the pupil diameter is also mentioned in this, which is very helpful in a case of refractive surgery, and the lens thickness is also provided. Now another parameter which is measured in this pentacam is the value of A sphericity, which is measured in the form of Q value. Why is that important is in a normal cornea, the peripheral rays are more refracted than the axial and the paraxial rays, which causes a spherical aberration. So when a cornea is extremely prolate, the peripheral rays will be focused behind the central rays, which will result in negative spherical aberration. Whereas in a case of oblate cornea, the peripheral rays will be focused in front of the central rays, which will result in positive spherical aberration. Now in the pentacam, you have another display which is being widely used nowadays for your refractive surgeries, before your refractive surgeries, and for diagnosing your early stages of keratoconus, which is known as the BAT display or the Bellin-Ambrosio enhanced ectasia display. It is based on the principle of the enhanced best fit sphere, right? So you have a best fit sphere, but this is utilizing the principle that since in a keratoconus or in any corneal ectasia, there is a particular part of the cornea which is only abnormal, that is thinned out, right? So you take into account that part of the cornea, you create another sphere on the basis of that location, so that even the slightest of the elevation or slightest of ectasia can be detected in the early stage. There is a parameter known as D value which is being provided on this BAT display. It comprises of 5 D values, which includes your DF for the front surface, DB is for the back surface, P for the pachymetric progression, T for the thinnest point, and Y for the thinnest point displacement. So an overall score of these 5 values is incorporated in the D value. What you need to know is that less than 1.6 diopter of the total D value is normal, more than 2.6 is abnormal, and anything in between 1.6 to 2.6 is suspicious. So there are 2 more parameters which are provided on the BAT display beneath this, which is known as the CTSP and the PTI, right? So PTI is the percentage thickness increase and CTSP is the corneal thickness spatial profile. I'll just tell you briefly that this is telling you the plus minus 2 standard deviation which is taken from the normative data. So the normally it should lie in between these dashed lines, right? So that means it is normal. So just after we have discussed everything, I would just like to review this map once again. This is how your pentacam map is going to look like. Once now we have discussed everything. So you need to, whenever the pentacam map is being shown to you, you will first look at the patient data. Then you will look at all the quantitative values that has been provided to you, which includes your K1, K2, the Kmax, the thinnest pachymetry. You are going to correlate it this on the 4 maps that has been provided to you, right? So on the sagittal curvature, the elevation and the pachymetry maps. And then once you have, for example, if you have localized that there is a steepening in some particular part of your map, on the, for example, if there is inferior steepening, so you have to correlate it on the pachymetry map as well, that the corresponding area has got thinning also, and on the elevation map, the corresponding areas have got elevation also, right? And this is the BAT display which you have for the front and the back surface. So this is for a normal cornea, so everything is green in color, but if anything suspicious was there, so then it will show in either yellow or red color, which I think will be discussed in the further presentations. And this is again for the normal maps. So you can see that the red line, which is the patient's data, is coming in between the plus minus 2 standard deviation. Thank you.
Thank you, Dr. Alisha. I think she has told very clearly what is the normal tomography and the topography. So after understanding this normal part, now Dr. Chintan is going to discuss what abnormality you should see in these various charts, especially on the pentacam. Any question from any student? Dr. Chintan can continue. Dr. Chintan is working as professor in PGI Chandigarh, so she is working in cornea. So I request Dr. Chintan to start.
Thank you so much, sir, and thank you, Dr. Alisha. I think you've made everything pretty simple. Pentacam is, basically the talk is on how to detect abnormality in corneal tomography and topography. Dr. Alisha has very elegantly expressed the difference between topography and tomography. One needs to understand that topography just gives us the anterior surface of the cornea. When we are trying to either screen patients for refractive surgery or we are trying to look for ectasias, what we want to know is that is there any pathology which is not shown on the surface but lies deep in the cornea. And that is the concept of what was talked about is the elevation, because most ectasias, whether it be keratoconus, whether it be ectasia developing after refractive surgery, that starts from the posterior surface. And your simple Placido devices just take the reflections of the anterior cornea. They do not measure the posterior cornea. And that is where your tomography comes in. So we understand that tomography is like a CT scan. So like you see CT scans of the orbit, the tomography is the CT of the cornea, right? So it is measuring both the anterior and the posterior surface. So once we have that concept in mind, let's see whether it's from any tomographer. The other concept one should have is that to do, because some of you later on may decide to become refractive surgeons, corneal surgeons. To do refractive surgery, it is an absolute must that you should have access to a tomographic device, which may be anything. It may be a pentacam, it may be a Galilei. Just on the basis of topography, refractive surgery cannot be done, and sometimes ectasias cannot be detected. So it's important to have access to a tomography, and the principles remain the same. So I'll just try to touch upon the principles which we have to look for, right? So since Dr. Alisha spoke about the pentacam, I am sticking to the pentacam per se. So what is the information that we seek from any device? Once we're looking at any device, we want to look at the shape, which means we look at the curvature of the cornea. Is it steep? Is it flat? Where is it steep? Where is it flat? We want to look at the thickness, because we know that in keratoconus or the ectasia's cornea is thin, or if we want to do refractive surgery, there are cutoffs beyond which we do not want to go. And then we want to look at the bumps, the lumps and the bumps in the surface, which is expressed by the elevation. So it's like you're going on a smooth road. The road may have a small dip. If you're going too fast, your ride will not be smooth. So it's the same concept for the cornea, the elevation, right? Now, so this to show this, the two black circles show these are the maps which we look at most usually. So you have the K readings on the top, the K readings from the anterior cornea, and then you have the pachymetry at the bottom, and of course the 4 maps which have been shown. So the curvature, the cornea can have different shapes. I mean, the anterior curvature can be different. For example, here and on the left you see the extremely symmetric bow tie, and on the other two sides you see an asymmetric bow tie of different variations. One is less steep, the other is more steep. So while we say that elevation is important, it is not that we can rule out topography. Topography itself is also very important, and a simple topographer also gives you a lot of information. So in fact 10 topographic patterns have been described for the cornea. You have something where the central area is round, you have an oval, then you have some areas on topography which show a superior steepening, you have an inferior steepening, it may be irregular, and then you can have bow ties. Now the bow tie, like I showed in the previous map, it may be completely symmetrical. The two lobes may be equal, but one is at an angle. So that is the first one shown there, symmetric bow tie with a skewed radial axis. The two lobes may be different, so that itself becomes an asymmetric bow tie. If the superior lobe is bigger, you say an asymmetric bow tie with superior steepening. If the inferior lobe is bigger, it's inferior steepening. And then those two lobes may either be like this or they may be like this. So basically the concept is the same, right? The circles which have been highlighted in green, the round and the oval, those are the patterns which we are most happy to see, because they are the ones which signify kind of normality. And the two on the right, the ones in the red are the ones which we are not so happy to see, because they are usually implying ectasia, right? So that is what we look at, the topographic patterns. So I'll break each of these maps into the different patterns, because we're talking about what is abnormal. So we looked at the central values, the sim K. So you saw on that left hand of the map, the K1, K2 and the K mean is given. This Km is the same value which, this is known as, these are the derived values. These are the same which you get in your normal, let's say in the IOL master, which you get, the simulated K readings. These are the K readings from the central 3.2 millimeters of the cornea. So if it is more than 47.2 and less than 48.7, it is considered, anything less than 47.2 is considered normal. Of course, I will again emphasize, you do not diagnose any abnormality on the basis of one parameter. It is always a combination, it's a composite picture, not a single part of a picture. But it's still helpful to remember these values. So, more than 48.7 is suspicious of an ectasia. More than 47.2 is just suspicious, and less than 47.2 is normal, right? And this is here shown in the red screen here, the Km value that I'm talking about. Then And like here we can see this is a pattern, we see that there is inferior steepening, right? But how do we quantify it? So if your inferior and superior difference of the K value is more than 1.4 diameters in the central cornea, the 3 mm of the cornea, that is suspicious. Or if your superior inferior difference is more than 2.5. Why these values are different is because ectasia is usually inferior. So we have a lower threshold. We've kept it as 1. By norm it's 1.5. Superior ectasias do occur, but they are rare. So the threshold is kept higher. We don't diagnose it so quickly, right? So now if I say that it's more than 1.4 on the 3 mm circle, is it just by visual inspection? No. There is a quantitative way in which you can do it. And that's on this. There's this another map which is known as the topometric staging, and the green arrow at the bottom shows you there's this value where it's shown this IS. So this is the inferior superior asymmetry. This is basically, so you measure 5 points on the software automatically does it, 5 points on the superior 3 mm circle, 5 points on the inferior. This is similar to your, you have in the visual fields, the glaucoma hemifield test. So same like that. So the average of the 5 values on the top and the average of the 5 values on the bottom, automatically this will give you this inferior superior asymmetry. So if it is between 1.4 to 1.9, it is suspicious, and more than 1.9 is again suggestive of ectasia. The second thing we come to after the curvature is the pachymetry, the corneal thickness. Like Dr. Alisha showed you earlier, the pachymetry can be defined in different ways. The map on the left top shows you the actual. So at this point it is 540, it is 560. The map at the bottom shows you relative pachymetry. So you have a normative database for that age of the patient, and it tells you that it is, 0.2% lower than normal or 0.2% more than normal. So that is relative. But mostly what we look at the absolute maps, and what she showed you is the distribution. So without going into the details of this, what these lines at the bottom, basically they are just telling you how the cornea is changing in thickness from one point to the other. In a normal cornea, the center is the thinnest, and gradually it will increase to the periphery. So you see at the bottom, as it's going down, the corneal thickness is increasing. If there is any area of irregularity in between, there will be some dips or waves like an ECG wave in the thing. So if it's normal, it's a normal distribution, right? Now, why is this okay, so I'll come to that later. Now, what is considered abnormal? So there are multiple things. If your cornea is too thin, the thinnest, less than 470 microns, it may be considered abnormal. I'm mentioning. If the difference between the two eyes at the center is more than 30 millimeters, the lowest point. So basically any asymmetry between the two eyes, more than 30 millimeters. If your superior inferior difference is more than 30 millimeters, that means one part of the cornea is, because normally also the inferior cornea is thinner. But if that difference goes beyond a certain limit, that's when it becomes suspicious, right? So the other 2 points I'll leave out. So any difference between the two eyes and any difference between the superior inferior value is suspicious. The other thing is those 3 lines that we were talking about. It's how the cornea is distributing from the center to the periphery is more important than an absolute value. And I will show you something about that later. So in fact, central pachymetry, the central corneal thickness, is the least reliable. We give that the most importance, but that's not so important, as is the distribution. So I'm re-emphasizing that how the cornea is distributing from the center to the periphery is important. And there are indices which have been given for that. I know it's too much for somebody to take in who probably may not have seen a pentacam map also, which is why I'm saying it is the concept which is important, right? So, and the other thing to remember is, so this is the map of a keratoconus patient. So you see that the bottom line is going a little below, right? The thing to remember is that there is always an overlap between abnormal and normal eyes. There will be some eyes which have abnormal some parameters, but the other parameters are normal. So 10% of cases with clinical keratoconus may have a normal pachymetric progression index, while others may be abnormal. So it's impossible for you guys to go into these parameters. Just remember that there is some overlap always between normal and abnormal eyes. And it is the distribution of the pachymetry which is more important than the central value. And the third is the concept of elevation, which again Dr. Alisha referred to. So you have the cornea, which is a bell-shaped cornea. The software, the algorithm fits in a shape which we think is best suited to that, right? So I always mention it as if somebody is wearing a very loose fitting dress or a tight fitting dress. If you want to hide the imperfections, you wear a loose fitting dress. But if you wear it too loose fitting, that's also not nice. So you want something which is just a little loose, which makes you look nice. So that's the concept of the reference surface. It's trying to hide the little irregularities, but we don't want to hide too much, right? We want the what is clinically relevant to be highlighted, right? So that is the reference surface, and anything which is above the reference surface by convention is given a plus value, and anything which is minus is given a minus value. So ectasias, like I mentioned, are either in the center or in the mid periphery for most of the things, keratoconus and all. So we look for these plus and minus values in the center and the mid periphery. The peripheral values in that sense are not so important, right? So what's abnormal? This also again has been mentioned in the previous talk. So you look for these patterns. You look for this island pattern both on the, so the anterior surface and the posterior surface are measured separately by the tomographer, and you get values for both. So these values have already been shown. If it's more than, so you look for these patterns, a island shape or a tongue shaped pattern, right? If you see that, and if in that pattern on the anterior surface it's more than 12 and on the posterior surface it is more than 17, then these are suspicious. And this again Dr. Alisha talked about. The concept of a Bell Ambrosio is just to highlight the subtle irregularities. Advanced cases you can see with anything. You can see even on a slit lamp. You will see vogued striae, you will see scissoring reflex. It is the early cases we want to detect. And when we want to detect the early cases, so going back to the concept of a tight or a loose dress, which can be for men or women, so no sexist comments here, please, that's okay, understand. So when we want to hide the little irregularities, we make it a little loose. When we want to highlight the irregularities, we make it a little tight. And this is exactly the concept here. When it was a little loose fitting, you have some part of the elevation which is hidden by that orange circle there, right? But when you want to highlight it more so that we don't miss anything and we make screening safer for patients, then you exclude that area, right? That this software automatically does. And you make it the fit is such that your abnormalities are highlighted. So this is just the concept. I don't know if there's a pointer here or not. In the central map that you see, on the left side of your screen, the central map that is there, that is the area where the machine has tried to give your reference surface a tighter fit so that so this is the normal what we saw on the previous map. Here, this red circle is that area which has been excluded. That area of the bump has been excluded. So you get a tighter fitting best reference sphere, and on top of that you superimpose. So that becomes more highlighted, and which is why you see that this is just a difference between these two. Whereas these two maps are looking completely normal. But this tells you that this area has some suspicion and there is a possibility of ectasia. So to summarize, remember that no single parameter can define abnormality on topography and tomography. It's a puzzle which has to be pieced together. So multiple factors have to be correlated, and values which are abnormal in a large majority will be normal for a small population. So that is the concept of 3 standard deviations. 3 standard deviations का मतलब होता है कि in 0.1% of that population, that value can be normal. And just to show some data, so like I mentioned, less than 470 is suspicious for ectasia, but in around 0.1% of the patients, a pachymetry of 450 is normal. And we often see that in clinics. They've been referred for ectasia something, but it's just that it's a thin cornea, right? And in the same way, 3 standard deviations, 0.1% of the patients with normal cornea can have a central K of more than 48, which I mentioned should not be more than 47.2. So to re-emphasize, you have to piece all the things together, and it is never one thing together. I will not repeat this. This has been repeated in the previous 2 talks. If you want, you can just take a picture of this. So basically, you look at the curvature, you look at the thickness, the distribution of the thickness actually, and you look at the elevations in the central and the mid-peripheral cornea, and taking a combination of that, you decide whether a patient has a normal topography and tomography or a abnormal topography. Thank you very much. So this is a little difficult topic, and I think you need to read up about it, but that's the general idea.
Thank you, Dr. Chintan. I think she has tried to clear each and everything. But until we see the map and study ourselves, then it is very difficult to
Yes,
learn.
absolutely.
So we have to remember the values, but we have to see practically, then we can understand. Thank you.
Thank you so much.